There's some questions out there. Quickly, I can answer a couple, then Fernando, I'm going to hand it over to you. One question was, do we use FiberSure? We do not. Fibrosis score of 3 or higher is what we would consider for heart liver transplant at Penn, along with CHOP. And most of them were AP Fontans. Those were my questions. The question I'll pose to the congenital group is that came from the audience is, if a patient's anatomy doesn't allow a PA catheter to be placed to measure PVR or hemodynamics, how do you assess them hemodynamically for suitability for heart transplant alone?
Thanks, Joyce. I have to admit that this is a tricky question because all the transplant centers would agree a PVR is crucial to decide about transplant suitability. I guess one way would be to see what actually is the matter. If what we cannot achieve is an correct wedge pressure, you could always try to perform left and right heart catheter, try to get as accurate mean as possible and evaluate the left ventricular end diastolic or the systemic end diastolic pressure. But I guess that's an easy answer, cheating answer. As far as I know, I don't think there is any replacement to an invasive evaluation for pulmonary vascular resistance. But I understand that with magnetic navigation or with any of my skilled colleagues, you could overcome many of the difficult access to actually get to the pulmonary vasculature and perform the measurement of the pressure. We perform in Herfield all our right heart catheter for these patients in collaboration with my interventional colleagues. So I guess we always have the luxury of that.
Great. Dr. Grushin, did you want to speak?
Sure. I just wanted to add something to that comment, if I may. And I apologize for gate crashing. It was actually on invitation, not pure gate crashing. The addition is not so tricky actually to measure PA pressures often, as Dr. Rosenthal will tell you. That's not so much a challenge as it is difficulty in measuring pulmonary blood flow from multiple sources. So, and this is where the challenge really comes if there's collaterals, if there's differential supply to lung segments and so on. And this is really where MRI comes into its own, and especially labs that have both MRI and cath facilities in the same setting. That really makes a very significant difference. So you can then truly calculate absolute pulmonary vascular resistance and obviously index as well.
Yes, I try to avoid diagnostic catheterization without an MRI for that reason, because you get a much better assessment of pulmonary vascular resistance.
Indeed. I guess there is another question that was directly posted to our center to whether Herfield would accept complex congenital patients for transplant or ventricular assist device evaluation. And I think the short answer is yes. We have a close collaboration with Brompton, from where we have a lot of referrals, and many of them have complex anatomy. We would perform the evaluation, and we will also be in contact with other centers if there are complexities that need further discussion. But the short answer is yes, we will be prepared to accept referrals for this.
Yes. Dr. Katsoulis?
Yeah. First of all, apologies for putting everybody under a lot of strain for the short time allocated. Excellent talks, all speakers, and a lot of strain for the chairs. Fantastic talks, really appreciative. I have a question or a comment maybe for Jane. Great talk, Jane. And I just wonder whether some of these barriers that you referred to pertain to us, the profession, rather than the patients. And I may be a fantasist, but if we were to engage with the patients and share with them kind of the projected life journey before they decompensate and they have a kind of urgent list of transplantation and mechanical assist device, they will have a rich but short life, some of them with complex disease, and they will be able to handle end-of-life care and death better. So death, in my books, a good death is part of a good life. It is a shorter life for patients with a fontan circulation. But if that communication and work took place from the time of diagnosis, this is obviously a very extreme statement, but I believe it to be true, then the whole journey will be richer. And some patients will end up having a transplant, but they will be in optimal condition. Obviously, we'll have more data from the work that all of us are doing in selecting patients at the better time, but some patients would not, and that's still a rich life. I just wondered, Jane, do you have any comments to it?
Yeah, I mean, I would absolutely agree with that. I think what we see in our sort of day-to-day practice, I suppose we have the luxury of working across the Royal Marsden and the Royal Brompton, where we are very integrated with multidisciplinary teams. So we are absolutely there alongside all the primary treatment therapies that are happening. And I suppose there's a few key things I would say. One is that patients actually welcome the opportunity to see us alongside their treatments. So we are considered to be another stream of parallel treatments going alongside it. But actually, when you open up the door to these conversations, it can relieve a huge amount of anxiety for patients and those closest to them to have those conversations when they are better, they're well, when they're in a much better physical condition, so that they can best inform their decisions later. And we're not then having crisis kind of talks when patients are critically unwell. So I think one of the concerns for us as clinical staff is that if we have those conversations early, how could we even address it? And are we going to make the patients more anxious? Or is it going to be seen as a barrier? It's an either or. You either have your treatment to modify your disease, or you have your symptom control. And for all of those reasons, to be able to have both conversations going along in parallel has demonstrated very significant improvements and outcomes for patients in cancer and outside it. So absolutely echo it. Early integration is the key.
And very briefly on this subject, we are confronted with this question when we advise women about pregnancy. And in my humble experience, all but one patient were very upset to have in a very rough estimate of their lifespan prognosis, which has to be part of the consultation. So I think the barrier, by and large, is within us, not with the patients. Thank you.
Absolutely.
Michael, I wonder if I can make a comment to that. One of the challenges, as you well know, is our busy clinics, and no excuse, of course. But if you've got 15, 20 patients in your clinic and you're spending 10, 15 minutes with each of them, it's really difficult to find the quietness inside of you to comment. But I was just going to make the comment, or one suggestion that really helps is we just tried a very simple questionnaire before the clinic. In other words, do you know what your diagnosis is? Do you want to know more about it? Question number 2, do you know the implications of your condition for the future? Do you want to know more? And third question, I forget. But that allows a very simple way of getting the patient then to volunteer information. And same with sexual health, actually, that's a really big deal that kind of goes alongside all of this.
Just very briefly on this, which is very important, Grusen, is that we have to change the clinic model. The virus has caused this. We cannot go back to bringing patients back to the clinic every year having an echo. This is dead. It's archaic. And we need to empower the patients. Stay on my talk at the end of the meeting, and you'll have a bit of a flavor of this. Sorry, I'm monopolizing, but I think this is obviously important. Yeah.
Thank you so much, Michael. I wanted to draw Sabina into the conversation. And Sabina, how embedded are you with your ACHD program and your transplant program in terms of when you start seeing or getting referred patients with arrhythmias? Are you referring them for transplant early, or are you thinking I can always ablate?
I would think I'm very much embedded. I think they have adopted me more or less. I feel more part of the ACHD group than probably the EP group. So we have a very close relationship. We all sit on the same corridor, so they are knocking at my door or coming up to the cath lab when they know that I'm in the lab. And we typically try to take a patient for the ablation. For example, let's say a mustard presents an atrial tachycardia. We try to take them to the lab, not go through multiple cardioversions. So we try to tackle the arrhythmia, you could say aggressively, with ablation early on, because we know we have a very good success rate. Access is not an issue with magnetic navigation. So same thing basically is true for Fontans. To be honest, I cannot even make a deception now. I don't, at least ad hoc, I don't find anyone that I can't be able to do to respond at least. Let's say set aside people who have large clots in the heart, for example, large clots in the Fontan. What we'll try to do is in our MDT, we discuss cases very carefully, and if there is remaining arrhythmia issues, again, the threshold for ablation is relatively low. And we have a short publication, I think, patients that were listed or were imminent to be listed, and I managed to sort the arrhythmia out in most of them, allowing them essentially to live long enough to wait for a transplantation that happened more than 1,000 days later, without constantly decompensating. Because, as you know, even if they only go to atrial tachycardia, they decompensate quickly. So
it's easier for us to delist a patient that got better than to list them when they're an extremis. So I like that idea of parallel referral.
Mm-hmm. Yeah, exactly. So we try to do both, and we try to do this relatively actively. So I would say my practice is about 40% congenital by now. I do about 70 ablations in a year for congenital heart disease. I think I can still do more if you say more. Yeah, but I think Michael and everyone in the group will say the same thing. And it's not only me alone, but there are several consultants who do interventions.
That's wonderful. Thank you. I know we're over time, but there was one question from the audience to Dr. Rosenthal. Is there any case of stenting of inferior sinus venosus ASD and any special attention to these cases?
There have been one or two cases of using the standard ASD device for inferior sinus venosus defects. But I guess these are really borderline secundant defects that are just slow down the septum. Stenting is potentially a problem because you may have to watch out for the hepatic veins, and also you would need a very large stent. Having said that, one of our junior colleagues who now has gone back to Münster has stented the inferior baffle of a mustard patient with an ASD, and that with a covered stent actually produced a very good result.
Wonderful. Thank you. Michael, do you want to close out the session?
Maybe you should, because there's a tight program to follow. But there will be opportunity, I think, for the delegates to interact with our excellent faculty during the course. So thank you very much. Wonderful. And we should come back at, let's say, 5 to 1 for London time. So in 8 minutes time, just a bit of a break. Thank you very much.